Welcome to the module, Seizures and Status Epilepticus. I'm Dave Zimmerman, Associate Professor of Pharmacy at Duquesne University and Emergency Medicine Pharmacist at University of Pittsburgh Medical Center, Mercy Hospital in Pittsburgh, Pennsylvania. This presentation is part of the ACCP and ASHP Emergency Medicine Pharmacy Specialty Review course, which is designed for pharmacists seeking to update their knowledge and skills in preparation for board certification. The activity is designed to be interactive, with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handouts. The disclosures are displayed on this slide. Let's take a look at our learning objectives. First is to identify initial management in medical emergencies using available patient-specific information. Next, evaluate medication-related problems based on presentations, history, medication use, and laboratory data. Third is to develop therapeutic and monitoring plans based upon medication-related problems, patient and disease-specific information, and laboratory data. Next is to summarize strategies for procurement, preparation, and administration of time-sensitive therapies. And last, modified treatment plans based upon a patient's response to initial therapy. These are some abbreviations that we'll use throughout the presentation. Let's start with a patient case. TK is a 54-year-old male who presents to the ED after a tonic-clonic seizure witnessed by his wife. The seizure lasted approximately 1 minute. The patient has never had a seizure before, and he and his wife report no trauma. EMS personnel responded and found TK in a post-ictal state. He was transported to the ED without any additional seizure events. His history includes hypertension, dyslipidemia, and myasthenia gravis. Home medications include lisinopril, atorvastatin, and pyridostigmine. Denies tobacco, alcohol, or illicit substances. His height, weight, and vitals are listed on the slide as well. So let's first talk about adult seizures and how we manage these in the ED. So seizures as a primary diagnosis led to more than 696,000 or 0.5% of all ED visits in the United States in 2018. Recall, seizures are events resulting from excessive abnormal cortical neuronal activity with a variety of symptoms. They can be classified as partial seizures, which occur on one hemisphere of the brain, or generalized seizures, which start on both hemispheres. When you look at partial seizures, you can have a simple partial seizure where the patient remains alert or conscious. You can have a complex partial seizure where the patient loses consciousness. And you can also have a secondarily generalized where the seizure starts on one hemisphere and then moves to the other hemisphere of the brain. With generalized seizures, these can be categorized as absence or absence, depending on what part of the country you're from, myoclonic, tonic-clonic, tonic, or atonic. In the handout, you'll find a description of each of these types of seizures. Something that we should also discuss that you will sometimes see is non-epileptic form seizures, sometimes commonly referred to as psychogenic seizures, although non-epileptic form would be the preferred terminology. These are manifestations of psychologic distress and do not have a neurologic origin. One retrospective study found 26.5 and 49.5% of presentations to the ET of two different cohorts with presumed seizures were of psychogenic or non-epileptic origins. Treating non-epileptiform seizures as epileptic seizures can lead to invasive testing and unnecessary treatment in the ED. We may be able to determine the difference as we witness patients having these events in the ED. But in the pre-hospital setting, it's not always, especially the lay population, it's not always easy for them to differentiate. So this is one of the reasons why we see patients being brought in. Additional information on this topic can be found at the reference by Gasparini et al. So there are a couple definitions of epilepsy. First, by the International League Against Epilepsy, or ILAE, they defined epilepsy as a disease of the brain and by any of the following conditions. So there's 3 operational definitions. You just need to have one. The first is at least 2 unprovoked or reflex seizures occurring greater than 24 hours apart. So I have an unprovoked seizure today. A week from today, I have another unprovoked seizure. I now will meet the definition of epilepsy per the ILEE. So we should note that the term unprovoked implies absence of a temporary or reversible factor lowering the threshold and producing a seizure at that point in time. A common example would be seizures related to alcohol withdrawal or hypoglycemia. The second operational definition is one unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk of at least 60% over the next 10 years. So I have a unprovoked seizure today, but because of the cause of that, I have a high risk of a second seizure occurring. We'll go ahead and diagnose that patient with epilepsy and can initiate anti-epileptic therapy. The last is diagnosis of an epilepsy syndrome. There are a number of different epilepsy syndromes out there and beyond the discussion of this presentation. Common ones that we may see include Dravet syndrome, Lennox-Gastaut, infantile spasms, and others. The American College of Emergency Physicians, or ACEP, clinical policy statement classifies seizures into two categories. First, as provoked, and this is equivalent to an acute symptomatic seizure that occurs at the time of or within 7 days of an acute neurologic, systemic, metabolic, or toxic insult. These can include hyponatremia or other electrolyte abnormality, including magnesium, withdrawal from medications or other substances, toxic ingestion, encephalitis, or CNS mass lesion. Unprovoked is seizures that occur without acute precipitating factors. So how are we going to work up patients in their ED? And this will first depend if the patient already has an established diagnosis of epilepsy or a history of non-epileptic seizures, or is this the first time seizure? So let's take the approach if this is the patient's first time seizure. So it's in general, we want to try to gather as much information as possible from the patient, witnesses, pre-hospital providers as they transfer the patient and give us report, or others involved. Some things that we may want to ask: what was the patient doing at the time of the event? Did they lose consciousness? Was there any trauma involved, falling or hitting the head, that might dictate need for CT imaging, especially to rule out either an intracranial process or a cervical fracture? What was the nature and duration of seizure, if they could explain the type of movements the patient experienced? What medications were received on the way to the ED, if any? And lastly, what's the patient's past medical history, including home medications? These include prescription, over-the-counter, herbal products, and potentially illicit substances. For patients with a first-time seizure, our standard workup include a physical exam and history. Typically lab test, definitely looking at glucose to rule out hypoglycemia. And this is something we can always get as a point of care test if it's not done in a pre-hospital setting. And then electrolytes, especially sodium and magnesium. CT imaging, and depending on results, can escalate that to MRI if it is abnormal. An electroencephalogram or EEG can possibly be done. This might not, depending on your hospital setup, be feasible in the ED, but this could be done either in an observation, inpatient, or outpatient setting, certainly with neurology following up on that. With a report of a seizure, we're certainly going to have a broad differential diagnosis. It can include, in addition to epilepsy, infectious causes like meningitis, encephalitis, toxins, medications or withdrawal from them, hypoglycemia, hyponatremia, uremia, tumor, and stroke, whether it's ischemic or hemorrhagic in nature. For patients with an established diagnosis of epilepsy, this might be a little bit more clear cut because we already know that they have seizures. So doing a physical exam, looking at their epilepsy history, how often do they have seizures? When they do have a seizure, what type of seizure and how long does it last? Is today's seizure any different than what they typically will present with? And is there anything that could be lowering their seizure threshold or causing seizures? One example would be an ongoing infection. We certainly want to look at medication history and assessment of compliance. This is something that I commonly see in the ED, and I'll ask the patients and just want to get to the bottom of it. You're prescribed X medication. Are you taking it? If not, tell me, because I want to know the answer, because we need to get you on a therapy that's going to work, because you can greatly harm yourself or others. So getting to and determine compliance, again, whether this is due to not understanding the disease state, cost of affording the medication, or side effects, or something else. Some of our anti-epileptics, we can get medication levels, and we'll talk about this in a little bit. Lab tests, again, just ruling out other causes, such as hypoglycemia or shifts in our sodium. And CT imaging may be indicated if the patient is not returning to baseline, or if there's any concern for trauma, to rule that out. So when should we initiate our AEDs or anti-epileptic drugs? So reversible and non-epileptic causes of seizures should be treated appropriately before considering anti-epileptics. Examples would be if a patient's hypoglycemic, giving them dextrose, or if we don't have IV access, glucagon. Treating alcohol withdrawal seizures with benzodiazepines, barbiturates, or other therapies. If we look at our policy statement, so looking at ACEP, they state anti-epileptics do not need to be initiated in the ED for patients who have had a first provoked seizure and their clinical status has returned to baseline. Anti-epileptics do not need to be initiated in the ED for patients who have had a first unprovoked seizure without evidence of brain disease or injury. Next, they recommend anti-epileptics may be initiated or deferred to coordination with other providers for patients who experience a first unprovoked seizure with a remote history of brain disease or injury. All of these are level C recommendation. Moving to another set of guidelines by the American Academy of Neurology and the American Epileptic Society, they recommend adults presenting with an unprovoked first seizure should be informed that the possibility of recurrent seizure is greatest within the first 2 years, usually 21 to 45%. For adults presenting with an unprovoked first seizure, use of immediate anti-epileptic therapy instead as of no treatment is likely to reduce the absolute risk by 35% over 2 years, but has not been shown to affect the quality of life. Furthermore, adults presenting with an unprovoked first seizure, use of immediate anti-epileptics instead of delaying treatment until a second seizure is unlikely to improve the likelihood of long-term sustained seizure remission greater than 3 years. Patients should be advised that the risk of adverse effects from anti-epileptics can range, but are predominantly mild and reversible. This would obviously depend on the agent that is selected, which is a perfect segue. Which agent should we select? So the guidelines that I mentioned do not give recommendations on specific agents. Okay, we have a variety of anti-epileptic agents out there that we can select from. Some of this may depend on certainly institutional formulary, the patient's age, concurrent medications, and assessing for drug interactions, concomitant disease states, and organ dysfunction, adverse effects of the medications, childbearing potential. We know certain agents, especially divalproic sodium or valproic acid, is an agent that we want to stay away from in patients with childbearing potential. Cost and need for laboratory and monitoring and follow-up. So again, they defer they defer the selection of an agent to fit what's best for the patient and the factors that you see on the slide. So let's go to our first question. TK undergoes a head CT scan with no evidence of injury or abnormality. Other results from his diagnostic workup are pending, but the tentative diagnosis is an unprovoked seizure. Which of the following statements about initiating anti-epileptic therapy in TK is correct? A, anti-epileptic initiation is appropriate based upon the ACEP policy statement because TK had a first unprovoked seizure. B, AED initiation is not appropriate based upon the ACEP policy statement because his seizure was unprovoked. C, anti-epileptic initiation is appropriate based upon the AAN AED guidelines because it will improve TK's quality of life. Or D, anti-epileptic initiation is not appropriate based upon the AAA guidelines because TK's highest risk of seizure recurrence is not until more than 2 years from now. So what do you guys think? Oh, the correct answer is B. Initiation is not appropriate based upon the ASAP policy statement because the seizure was unprovoked. Answer choice A is incorrect, as TK does not need to be initiated, as it's his first unprovoked seizure. C is incorrect, as the initiation of an anti-epileptic has not been proven to improve the quality of life, although it can reduce the absolute risk of seizure by up to 35%. D is incorrect, as the highest risk of seizures is within 2 years. So another common question that we're faced is whether we should check levels of the anti-epileptics for patients that are on them. This is certainly reasonable if the assays are available and there are concerns about non-adherence. If I'm discussing with a patient and they tell me they take their medication, they're compliant, no missed doses, I get a level, returns is 0, I know that's not true, okay? Or for potential adverse effects or toxicity, it's certainly reasonable then. We do have therapeutic ranges for our older agents, such as phenytoin, carbamazepine, and valproic acid. But the evidence from our newer agents and whether they actually benefit or not is lacking. One example would be with levetiracetam. So in general, anti-epileptic levels may be available in an expedited fashion to influence care in the ED. Depending on hospital setup, if your result comes back quickly, they can certainly assist you in managing the patient. But this will depend on institution and laboratory capabilities. If the level will not return in a timely manner, it has to be sent to an outside lab, then you should obviously realize that it's not going to impact the initial management now, but you should have some mechanism for follow-up on that, whether it is on the inpatient or outpatient basis, whether the patient is getting sees a neurologist or primary care, whoever manages their epilepsy. If it is a level that does return in the ED, and the patient is subtherapeutic, so let's say we get a phenytoin level, the patient presents with a seizure, we get our level, it's subtherapeutic, then we can certainly give a loading dose to achieve therapeutic concentration. This can be either given intravenous or oral, depending on clinical situation, and the handout will go into more detail on that. So let's now move on to pediatric seizures. Similar to adults, there is a plethora of causes, both provoked and unprovoked, for a seizure to occur. Some of these are not limited to epilepsy, electrolyte abnormalities, I mentioned sodium, magnesium, toxins, infection, inborn errors of metabolism, eclampsia, trauma, fever are common causes. Something that we'll see that's a little bit different in peds than from adults is a febrile seizure. So febrile seizures is one of the most common types that we'll see in the ED and can affect up to 4% of the population and account for almost 1/3 of pediatric seizures that we see in the ED. A febrile seizure is defined as a seizure accompanied by a fever of 100.4 degrees Fahrenheit or 38 degrees Celsius without central nervous infection in children 6 through 60 months of age. A febrile seizure is further broken down into simple and complex. A simple febrile seizure is a febrile seizure that occurs once and lasts less than 15 minutes, whereas a complex febrile seizure recurs within 24 hours and/or the initial seizure lasts longer than 15 minutes. It's important to differentiate as our management will differ between these depending on which type of febrile seizure the patient has. When we look at it from a diagnostic perspective, we want to focus on the identifying cause. We can perform a lumbar puncture for a patient who presents with fever and meningeal signs, which include neck stiffness, Kernig signs, or Brzezinski signs. We can consider an LP for infants between the ages of 6 to 12 months lacking Haemophilus or strep pneumo vaccination, or if vaccination status cannot be determined. Neuroimaging, EEG, and measurement of serum electrolytes are not necessarily required for a patient with a simple febrile seizure. A non-febrile seizure and a complex febrile seizure is going to include a more extensive workup. With this, we'll take a look and do a physical and neurologic exam, past medical history, including any medications, whether they're prescription, over-the-counter, or herbal, doing a complete blood count, electrolytes, glucose, evaluation for infection, potentially a lumbar puncture, toxicology screening, neuroimaging, whether it's just a CT scan and or MRI, and possibly an EEG, depending on capabilities of the institution, if this can be done in the ED observation or inpatient side. When it comes to management of the first unprovoked pediatric seizure, the AAN and Child Neurology Society recommend treatment with an antiepileptic is not indicated for preventing the development of epilepsy. Treatment with an antiepileptic may be considered in circumstances where the benefits of reducing the risk of a second seizure outweigh the risk of pharmacologic and psychosocial side effects. Now, switching gears to one of my favorite topics is status epilepticus, and we'll first talk about adults and then discuss management of pediatric patients. So mortality can vary depending on the etiology of status, but can be as high as 30%. Some common causes include stroke, metabolic abnormalities, hypoxia, systemic infection, or subtherapeutic concentrations. There are two major forms, convulsive and non-convulsive. So convulsive is defined as convulsions associated with rhythmic jerking or tonic-clonic movements. Non-convulsive is seizure activity seen on EEG without clinical findings associated with convulsive status. Non-convulsive status has definitely gotten more attention in the recent years, and the reason for that is it can be under-recognized in the ED due to the non-specific signs and symptoms and the requirement for an EEG, which may not be feasible in the ED for institutions. Common features of non-convulsive status include altered mental status, speech disturbance, myoclonus, and unusual behavior. Fortunately, the treatment for non-convulsive is extrapolated from convulsive and almost identical in nature. So let's take a look at our guideline definitions. So first, starting off, we have the Neurocritical Care Society by Brophy et al. Defines status as 5 minutes or more of continuous clinical and or electrographic seizure activity, or recurrent seizure activity without recovery, patient's clinical status returning to baseline between seizures. Prior to this guideline, status was typically diagnosed at a time period of 30 minutes, as that's when we first had evidence of permanent neuronal injury. However, we know that if a patient has been seizing for 5 minutes, then the likelihood that they will be seizing at 30 minutes is high. Therefore, the Neurocritical Care Society used a more aggressive timeline of 5 minutes. That way we can get our treatment on board in a faster manner. The Anti-Epileptic Society also utilizes a 5-minute duration for the diagnosis of status. The ILE are pretty similar, although I think it's a little bit more confusing or complex. They define status as a condition resulting from either the failure of the mechanisms responsible for seizure termination or the initiation of mechanisms that lead to abnormally prolonged seizures. They use two different time points, T1, which is after the abnormally prolonged seizure, and then T2, which can lead to long-term consequences, including neuronal death, neuronal injury, and alteration of neuronal networks. From their operational definition, they use time 1, when a seizure is likely to be prolonged, leading to continuous seizure activity. They specify tonic-clonic of 5 minutes, or a partial seizure with impaired consciousness of 10 minutes, or an absence seizure of 10 to 15 minutes. For time 2, is when a seizure may cause long-term consequences. And again, this is what we already mentioned, tonic-clonic of 30 minutes, or focal with impaired consciousness of more than 60 minutes, with absence unfortunately unknown. So for treatment of status, the way I like to teach this is we're going to give kind of two types of therapies. The first one is emergent with an E. Okay, this is the first thing we want to reach out of our dispensing cabinet to give to the patient. Historically, lorazepam has given via the IV route has long been considered the first line benzo compared to midazolam or diazepam for the emergent treatment of status. The reason for this is because it's kind of counterintuitive. Lorazepam is less lipophilic than midazolam and diazepam. Although midazolam and diazepam will get into the CNS quicker, it would also leave the CNS quicker. Therefore, lorazepam will have a longer duration of its anti-epileptic activity. It wasn't until we had the Rampart study, which was published in 2012. This was a double-blinded, randomized, non-inferiority trial comparing IM or intramuscular midazolam with IV lorazepam in children and adults with status in the pre-hospital setting. You can imagine patients in the pre-hospital setting don't really have IV access, and this can be quite a challenging for our pre-hospital personnel in trying to get IV access in patients that may have convulsions. Therefore, what if we went a different route and gave it intramuscularly? The results from the study showed a primary outcome of absence of seizures at arrival to the ED without need for rescue therapy of 73% in the midazolam group versus 63% in the lorazepam group, an absolute difference of 10%, which was statistically significant for non-inferiority and superiority. This has thus kind of changed our paradigm shift. If we have IV access, then certainly you can give lorazepam. However, if you don't have IV access, then we can no longer have to worry about getting that. We can grab our dose of midazolam and give that intramuscularly, get that on board, and then try to get IV access. Certainly, this also depends on what is stocked in your ED and available preparations. When we look at dosing, lorazepam is typically dosed at 0.1 mg per kg with a max of 4 milligrams and may repeat in 5 to 10 minutes. In these situations, we may be estimating their weights. So we do the best we have in those situations. With midazolam, the dose is 0.2 mg per kg intramuscularly up to a dose of 10. Midazolam can also be given intranasally. This is done a little bit more in the pediatric setting, and this is given at a dose of 0.2 mg per kg. But it's less well studied in status. So if we have the option between the two, intramuscular would be the preferred route of administration. Another option for adults is diazepam, dosed at 0.15 mg per kg intravenously, and you can repeat this in 5 minutes. In my practice, I'm reaching for either typically lorazepam or midazolam, depending on my access. So let's go to question 2. Unfortunately, TK had another witness seizure after returning from his CT scan. His clinical status did not fully return to baseline, and he's thus diagnosed with status. The attending physician asked for a benzodiazepine to treat TK's seizure. TK has a patent 20-gauge peripheral IV. Which of the following would be the best option for this time? And also pointing out that TK weighs around 85 kilos. So answer choice A, midazolam 5 milligrams intramuscularly. B, midazolam 10 milligrams intranasally. C, lorazepam 2 milligrams intravenously. Or D, lorazepam 4 milligrams IV. So the correct answer is D, lorazepam 4 milligrams IV. So remember, our first line options include lorazepam IV or midazolam IM. Lorazepam should be dosed at 0.1 mg per kg. With the patient weight of 85 kilos, that would max us out at 4 milligrams. So making D the correct answer and C incorrect because this is too low of a dose. Answer choice A is incorrect, as the dose for IM midazolam is 0.2 mg per kg with a max of 10 milligrams. Based upon TK's weight, he should receive that 10 milligram IM dose if we wanted to give midazolam. Answer choice B is incorrect, as intranasal is less preferred in adults compared to intramuscular when we're looking at giving midazolam. So moving on, we get our emergent therapy on board, right? Emergent therapy with an E is the first thing we want to grab and administer to the patient. At this point, we do not have time to relax. We need to get our urgent therapy on board as soon as we can, okay? So selection and preparation of an urgent therapy should take place while we're giving that emergent therapy to avoid any delayed administration. Historically, phenytoin or fosphenytoin or valproic acid were generally considered first-line urgent therapies in adults for the treatment of status until we had the publication of ESET. So ESET is a landmark randomized blinded trial in which levetiracetam at a dose of 60 mg per kg with a max of 4,500 milligrams, or fosphenytoin 20 milligrams of phenytoin equivalents per kilogram with a max of 1,500, or valproic acid 40 mg per kg with a max of 3,000 milligrams was administered over 10 minutes to 384 adults and children with status epilepticus refractory to benzodiazepines. This is a great study to do a journal club and top discussion on, and one of our landmark treatments for management of status. The incidence of the primary outcome of absence of clinically apparent seizures and improving responsiveness at 60 minutes after the start of the trial was 47% in levetiracetam group, 45% in phospheni, and 46% in valproic acid, all non-inferior to each other. And again, I want to point out that these drugs were administered over 10 minutes. Where I'm at my practice site, we were one of the study centers for this trial. So in addition to the primary outcome, there is no significant difference in rates of safety outcomes, whether you're looking at hypotension that can occur, especially with our phenytoin preparation, cardiac arrhythmias, which can also occur with phenytoin, or death. One of the major takeaways, though, of this therapy was, overall efficacy was less than 50% for each of those agents, and up to 20% of patients required intubation within 60 minutes. This is going to highlight the need for escalation of care. So even if we get our emergent therapy on board, we immediately go for our urgent therapy, get that prepared and administered to the patient. You should, in the back of your head, always be preparing for the need for additional urgent therapy and or intubation that may be needed, as these agents may not be successful. The workbook goes into some additional talking points or discussion points with this study. Again, one of my favorite studies to go into. So let's look at our individual agents for status in adults. We'll first talk about phenytoin. Phenytoin is dosed at 20 milligrams per kilogram. There's no specific dose cap that's recommended in the guidelines. In practice, usually you see around 2,500 to 3,000 milligrams. When you look at patients that are large body weight, we have different body weight dosing equations out there just in general. You have total body weight, ideal body weight, adjusted body weight, lean body weight, free fat mass, and the list goes on. For a lot of medications, we can look at using ideal body weights or adjusted body weights in patients that are large body weights. Well, with phenytoin, we actually do have some pharmacokinetic data that was specifically done in patients that were large body weights. And what they found is phenytoin actually distributes further into tissue. Okay, so when we do an adjusted body weight equation, and the workbook goes into more detail on this, when you typically think of an adjusted body weight equation, you have ideal body weight plus some type of factor, usually 0.4 times the quantity, total body weight minus ideal body weight. And this makes sense for drugs that are hydrophilic in nature, like aminoglycosides. Well, with phenytoin, because it distributes further into tissue, you actually need to give more. So instead of a 0.4 factor, what they saw in the study was it distributed 33% more into adipose tissue. Basically, the volume of distribution was larger. Therefore, instead of 0.4, that factor should be 1.33. Okay, and this may scare you some because your adjusted body weight, which you typically think is going to be lower than total body weight, will actually be higher. Okay. If you don't feel comfortable giving this large of a dose, then you can certainly give as high a dose as you're comfortable with. And then 2 to 4 hours later, you can check a level, depending on institution and turnaround time, probably going to be a total level. Some may have a free level that returns pretty quickly, but you can check this and wait at least 2 hours for distribution to take effect. And if the patient is subtherapeutic, you can give an additional dose after that. When you look at administration, phenytoin does require dilution at a max rate of 50 milligrams per minute due to the risk of hypotension and arrhythmias. Remember, phenytoin is a sodium channel blocker. Because it can precipitate out of solution, an inline filter should also be utilized. It's only compatible with normal saline and has a shorter expiration compared to other therapies. With phenytoin, this is probably not breaking news to you. It's a narrow therapeutic index drug with multiple drug interactions. Phenytoin is an inducer. It's highly protein bound to albumin. In patients that are critically ill, we can obviously have albumin shifts that can make phenytoin management more difficult than we would like on the inpatient side. It also has a therapeutic a range, typically 10 to 20 for the total concentration. When you look at side effects, things that we'll typically see, and again, this is kind of more so on the immediate administration side, arrhythmias, hypotension, extravasation, and then purple glove syndrome can also be seen. So that's why they developed fosphenytoin. Fosphenytoin is your prodrug of phenytoin. It's more aqueous and safer from an administration perspective. Fosphenytoin is now dosed in phenytoin equivalents to prevent any type of dosing error. So anytime you see it, it's going to be dosing, milligrams and then PE afterwards, which is the phenytoin equivalent. We typically give a dose of 20 mg per kg IV. Again, no specific dose cap is generally recommended, but you'll typically see is 2,500 to 30 milligrams. So we have some evidence with phenytoin in patients that are large body weights, but we have even less evidence with fosphenytoin. We do have one study by Dasgupta and colleagues that the workbook goes into, and they found a dose of 17 mg per kg based upon total body weight achieved therapeutic concentration, so potentially a little bit lower dose. When you look at practical considerations, it's typically a safer alternative to phenytoin from an administration, as it's more aqueous. It's available in multiple different solutions, including saline, dextrose, and lactated ringers. And it has a faster infusion rate of 150 milligrams per minute compared to 50 milligrams per minute with phenytoin. That being said, remember, it's a prodrug and does take time for conversion to take place. So a lot of times now, as fosphenytoin is a less expensive alternative, institutions, you may just stock fosphenytoin or phenytoin in your ED if you do stock it. Sometimes it's limited to central pharmacy for admixture there. You may limit it to just one preparation to prevent any type of errors from occurring. Next up is levetiracetam. The dosing per the guidelines is 40 to 60 mg per kg, although the ESET study used 60 mg per kg with a cap of 4,500. It has emerged as one of our first-line therapies, typically because it's an easier drug, right? Minimal drug interactions, mild adverse effect profile, better tolerated, and safer from an administration perspective. The one thing, and this is a great discussion, you'll see this on Twitter or other forums, is how we administer levetiracetam. So package labeling recommends a max concentration of 15 milligrams per ml. But if you're given 4,500 milligrams, that's a large volume and not something that you can give over 10 minutes. The ESET study used a 50 milligram per ml concentration. And again, the doses were given over 10 minutes. We do have evidence that IV push is a potential option, and typically used with lower doses, like 500 or 1,000 milligrams. But we do have one retrospective study that included doses up to 4,500 milligrams and given IV push, and it was well tolerated. There are, the downside to that is the number of vials that you would need to draw up. Typically comes as a 500 milligram preparation. So if you give 4,500 milligrams, you're talking about 9 vials. Not impossible, just a limitation. Your other option is to utilize a premix solution. There are a couple available in the United States. They're lower doses, like 500, 1,000, or 1,500 milligrams. So you would typically have to give several premixes, which again can be done, but we just need to make sure, sometimes doses have to be rounded or need to keep track of our bags to make sure that we give the correct amount. So there's potential for errors. And again, no ideal solution at this time. Otherwise, it's a very well tolerated. When you look at, adverse effects seen from an administration perspective, you're looking at something mild like dizziness. Our last one is going to be valproic acid, dosed 20 to 40 mg per kg IV with a max of 3,000 milligrams. This can be administered up to 10 mg per kg per minute. Similar to phenytoin, we do have numerous drug interactions that can occur. Valproic acid is also highly protein bound, and we can have altered albumin, especially in our critically ill patients, which makes it more difficult to manage on the inpatient side. One of the biggest things, and again, we can use valproic acid in other situations as well, such as migraines. One of the things, my pet peeves I always bring up to students, residents that are precept, EM residents, nurses, is we want to avoid, this is a bad drug when it comes to teratogenicity and birth defects. So if I have a patient that's pregnant or of childbearing potential, I'm going to typically avoid unless it's my only option. Okay. From an administration perspective, it's pretty well tolerated. Dizziness is something that you can see. Outside of that, side effects that we may see on the inpatient side include thrombocytopenia, hyperammonemia, and potentially liver toxicity. Again, those are all more rare compared to something like dizziness. So what do our guidelines recommend? So let's first take a look at ACEP and their clinical policy statements. They recommend additional antiepileptics should be administered in the ED. Okay, don't wait for the patient to get upstairs or somewhere else. They recommend with a level B recommendation of phenytoin, fosphenytoin, or valproic acid. And then for a level C recommendation, levetiracetam, propofol, or barbiturates. If we look at Neurocritical Care Society, they have valproic acid as a class 2A, level A recommendation. Phenytoin or fosphenytoin, slightly lower, and then levetiracetam as class 2B or a level C recommendation. The American Epileptic Society has fosphenytoin and levetiracetam recommended as a U and valproic acid as a B. They don't specifically recommend phenytoin, they just include fosphenytoin. With that, it's important to note that all of these guidelines and position statements were published prior to the results of the ESET study. And that's the reason, or most likely one of the reasons why levetiracetam has a lower recommendation, because we didn't have as much evidence prior to this study being published. So let's go back to our patient case with TK. He's again, a 54-year-old male. He presented to the ED after a tonic-clonic seizure witnessed by his wife. The seizure lasted approximately 1 minute. He had never had a seizure before. He and his wife report no trauma. Unfortunately, TK had another witness seizure after returning from a CT scan. His clinical status did not fully return to baseline, and he is diagnosed with status. And he was given an initial dose of a benzodiazepine. Recall his weight of 85 kilos and a height of 6'1". It's a rare situation where we actually know their height and weight. So looking at question 3, the attending physician again asked for your assistance in recommending an urgent antiepileptic therapy. Which of the following would be the most appropriate for TK? A, levetiracetam or levetiracetam, depending on what part of the country you're from, 4,500 milligrams IV over 10 minutes. Valproic acid, 1,800 milligrams IV over 60 minutes. Phenytoin, 1,000 milligrams IV over 10 minutes. Or levetiracetam, 1,000 milligrams IV over 10 minutes. What do you think the correct answer is? So A is going to be our best choice here. Levetiracetam at a dose of 4,500 milligrams as it's dosed at 60 mg per kg and given over 10 minutes. Levetiracetam is a good option, right? Unfortunately for answer choice D, that is too low of a dose. Remember, we want to give 60 mg per kg. Regarding answer choice B, valproic acid can also be used. However, given at a rate of 60 minutes is a little slow, right? We can give it up to 10 mg per kg IV. We want to get this drug on board, so let's give it over a faster time. Answer choice C is going to be incorrect, as that's too low of a dose, okay? It also exceeds the rate of 50 milligrams per minute. So in this situation, levetiracetam would be the best option. In practice, again, you can make an argument for all 3 of these, just depending on the dose and rate that you want to give it. However, the attending physician decides to use phenytoin because that is the antiepileptic that she is the most familiar with. No problem, no biggie. So which of the following statements about phenytoin administration to TK is correct? So A, phenytoin is compatible in D5 and 0.9% sodium chloride. Almost said normal saline there, but as we know, that is not normal saline. We call it abnormal saline. Anyways, I go on a tangent. Next up, B, phenytoin can be given via the IM route if IV access is not available. Or C, phenytoin can cause hypertension, so the blood pressure should be monitored closely. Or D, phenytoin administration requires the use of an inline filter. What do we think is the best answer? So D, phenytoin requires use of an inline filter as it can precipitate from solution. A is incorrect as it's not phenytoin is not compatible in D5W. B is incorrect as phenytoin should be given only via the IV route. Technically, fosphenytoin could be given via the intramuscular route. And C is incorrect as phenytoin can cause hypotension, not hypertension. Let's move on to refractory status. So we've given benzos as our emergent. We've given an initial urgent therapy, but the patient had a recurrent seizure. What should we do? A, give another dose of a benzodiazepine. Okay. And now we want to get another urgent therapy on board. Remember in ESET, efficacy was less than 50%. So you should be prepared after we give our first urgent antiepileptic and should already be considered deciding on what your backup option should be. So what can you use? Well, you can use an alternative first-line urgent antiepileptic. So if we gave levetiracetam first, let's give phenytoin, fosphenytoin, or valproic acid. Other options include phenobarbital at a dose of 15 to 20 mg per kg, and this can be given at a rate of 50 milligrams per minute. With phenobarb, we can certainly see hypotension and sedation and respiratory depression with these doses used. So certainly caution. Another option could be lacosamide. This is another sodium channel blocker. Typically doses of 200 to 400 milligrams IV over 15 to 30 minutes. We do have some data with lacosamide giving IV push, which we'll talk about in a little bit. It's certainly a promising therapy. I think it's a good option, especially going on a higher dose of 400 milligrams, but we just don't have evidence for it outside of refractory status. So this is where we kind of place it in therapy until we can compare it to other first-line urgent therapies. Side effects that you may see with lacosamide, dizziness, hypotension, PR interval prolongation, abnormal vision, diplopia, and ataxia. This is an agent that we don't see as commonly, especially given the IV route. So this may or may not be stocked in your ED. So that could be another thing that may impact your choice. So patients who have failed 2 urgent therapies and still in status may require intubation. 20% of the patients in ESET required intubation by 60 minutes. So if that's the case and they're mechanically ventilated, we have a couple additional options that we could use. These include continuous infusion propofol, benzodiazepine, or ketamine. Now moving on to AED procurement, preparation, and administration. So an ideal agent would be given quickly and be associated with low rates of administration-related adverse effects. None of this hypotension, PR prolongation, arrhythmias, none of that stuff. We want some of our agents, we have a maximum recommended infusion rate that limit how fast we can give them. Remember, phenytoin, 50 milligrams a minute, fosphenytoin, 150 milligrams per minute, and some require use of inline filters. We do have some data for some of our therapies to be given IV push, such as levetiracetam and lacosamide, and this has been shown to decrease the time from order verification to administration. So this could be an option. But not every ED is created equal, right? This depends on how your ED is set up along with your hospital. Are you a standalone ED? Are you an ED with pharmacy service 24/7 in ED? Maybe you're at a hospital that doesn't have 24/7 in the hospital, okay? Are you in an ED that treats both pediatric and adults in the same ED, or is there a separate space and separate automatic dispensing cabinets that you can separate meds? So all of these should be taken into consideration, and there's not one best answer, right? What I do at my institution may be different than yours just because of the setup, and that's fine. But what should happen is you should convene an interprofessional group to determine the optimal agents and administration and what can be stocked in the ED versus what should be prepared in central pharmacy. Okay. Remember, doses that we give for status are going to be higher than your standard maintenance dosing. So when it comes to stocking, you may need to increase your PAR levels to ensure you have an adequate amount. And lastly, staff education and informational tools should be utilized to ensure the safe preparation and administration of antiepileptics in the ED. Now we're going to move on to status in pediatric patients. So easy thing is our guideline-based definitions of pediatric status are the same for adults, okay? Causes can include subtherapeutic levels, neuroimaging abnormalities, electrolytes such as sodium, magnesium, or glucose abnormalities, inborn errors of metabolism, CNS infection, and ingestion of toxic substances. From a diagnostic perspective, it's vital to check for reversible causes, so getting labs, imaging, and EEG monitoring, depending on institutional capabilities. Genetic testing may be considered, although it can have limited utility in the ED because results may take a while to return, but it's not wrong to get that process started as it can help expedite diagnosis. What do we give from a treatment perspective? So benzos are going to be our preferred option. Lorazepam via the IV route at 0.1 mg per kg up to a 4 milligram dose, and this can be repeated after 5 to 10 minutes. Midazolam as a weight-based dose given intramuscularly, 13 to 40 kilo patients, 5 milligrams IM. If they weigh more than 40 kilos, then 10 milligrams IM, or a straight weight-based dose of 0.2 mg per kg up to 10 milligrams per dose. With diazepam, there is a per-rectal suppository formulation that can be used at a 0.2 to 0.5 mg per kg up to 20 milligram per dose, or 0.15 to 0.2 mg per kg IV up to a 10 milligram dose. For our urgent therapy, similar options, phenytoin and fosphenytoin at doses of 20 milligrams per kilogram. Levetiracetam, doses 20 to 60 mg per kg, and valproic acid 20 to 40 milligrams per kilogram. Valproic acid should be avoided in patients with known myocardial or metabolic disorder due to risk of hepatotoxicity, and phenobarb is another option for the guidelines. Again, these were all published and all these guidelines were published prior to the results of ESET, which did include pediatric patients. When you look at refractory status, we can certainly use a second urgent therapy that we didn't first use, okay? Other options include, again, depending on if the patient is intubated or not, continuous infusion of benzos, ketamine, pentobarbital, or lacosamide. Propofol is typically avoided due to in pediatrics due to concerns about propofol infusion syndrome. But if they're comfortable using it at your institution, you want to go for it, go for it. Patients from newborn up to 3 years of age should receive IV pyridoxine, though, in case of seizures are pyridoxine dependent. Let's move and switch gears to myasthenia gravis. So as we probably know, it's a rare autoimmune disorder caused by antibodies against acetylcholine and the postsynaptic receptors at the neuromuscular junction. Something that we'll see for patients in the ED regarding myasthenia is a myasthenic crisis. And this is a clinical diagnosis defined by respiratory failure in a patient with a history of myasthenia. Management is typically primarily supportive in nature. Patients will typically be hospitalized. They can be given IV corticosteroids, typically large doses, plasmapheresis, or both, and other therapies may be warranted. In my institution, we typically do plasmapheresis plus or minus steroids. If airway support is needed, if we can, trial non-invasive positive pressure ventilation like BiPAP or CPAP prior to going to mechanical ventilation. But if mechanical ventilation is required, then we will need to use our RSI medications, which include given a paralytic. So if we do RSI, rocuronium is going to be preferred over a depolarizing agent like succinylcholine. The reason is succinylcholine has unpredictable response and large doses may be required in patients with myasthenia. So skip sucks, go right to rock. Doses of this non-depolarizing agent, though, should be reduced by 1/2 to 2/3 as patients with myasthenia can be partially sensitive to these agents. So typically for ROC, we typically give doses of 1 to 1.2 mg per kg in a normal adult. We should give 0.3 to 0.6 mg per kg. Another option, again, depending on comfortability with the person that's intubating and the team, is to do an awake intubation and avoid use of a neuromuscular blocker. Just a quick recap, I'm sure we're all aware, but whether the patient has a myasthenic crisis or not, there are medications that we would like to avoid as it can worsen and lead to weakness at the neuromuscular junction. These include aminoglycosides, fluoroquinolones, macrolides, magnesiums, and others listed on our slide. Again, this is always a risk versus benefit. If a patient has a severe life-threatening infection and only a fluoroquinolone is going to work, well, then you have your answer there. But we typically want to avoid these if possible. For magnesium, if we're doing it for electrolyte repletion, outside of the patient has an arrhythmias, consider giving oral magnesium instead of IV mag. So let's move to question number 5. TK is unfortunately not protecting his airway after his second seizure and requires rapid sequence intubation. Which of the following neuromuscular blocking agents should be used for TK? Rocuronium at 1.8 to 2.4 mg per kg. B, succinylcholine 1 mg per kg. C, rocuronium 0.3 to 0.6 mg per kg. Or D, rocuronium 1.2 mg per kg. And I will let you ponder for just a couple seconds. So the correct answer is C, rocuronium 0.3 to 0.6 mg per kg. So remember, we want to avoid answer choice B in succinylcholine in patients with myasthenia as the response is unpredictable. Rocuronium, the dose should be reduced by 1/2 to 2/3, making 0.3 to 0.6 the best answer. Answer choice D, rocuronium 1.2 mg per kg is your typical dose that we would use in adults. And A would be incorrect as we want to lower the dose, not increase it. So now we're going to switch gears completely and talk about conducting research in emergency medicine. Why? Because we talked about some studies that enrolled patients in this type of scenario. So research in emergency medicine is vital, but it can be difficult due to the need to provide timely treatment and difficulty in evaluating patients, especially inclusion-exclusion criteria, and lastly, obtaining informed consent. Numerous trials, including ESET, rely on exceptions to informed consent in emergency situations, and this is governed by the FDA regulation 21 CFR 50.24, and this is the federal code that applies to emergency research and guidelines, the Institutional Review Board, or IRB, in approving proposed projects. Potential subjects, so who meets criteria from exception from informed consent? Potential subjects are in a life-threatening situation and available treatments are unproven or unsatisfactory. And collection of scientific data is required to determine the safety and effectiveness of the experimental intervention. Obtaining informed consent is not feasible. Also, participation in a research study holds out the prospect of direct benefit to the subjects. And lastly, research could not be practically carried out without the waiver. There are protected populations, though, that are excluded from the eligibility for this waiver, and they include fetuses, pregnant women, prisoners, and human in vitro fertilization. In the end, the IRB is responsible for evaluation and approval of the request to waive informed consent requirements. And this brings us to our last question. TK is being evaluated for inclusion in a new prospective randomized controlled study of a new unproven second-line urgent therapy for status. He is intubated and sedated, and his situation is considered life-threatening. The research personnel are unable to reach his wife to explain the potential benefits for TK for participating in the study. Which of the following statements about waiver of informed consent requirements for TK to participate in the study is correct? A, consent cannot be waived because his wife cannot be reached. B, consent cannot be waived because he is in a life-threatening situation. Or C, consent cannot be waived because he is in a protected population. Or D, consent can be waived because the new therapy is unproven. Our correct answer is B. Answer choice B is correct per our federal code 21 CFR 50-24. As this details appropriate situations when informed consent can be waived. Answer choice C is incorrect as protected populations are excluded from eligibility for this waiver. And answer choice D is incorrect as requirements is for patients to directly benefit from this study. Some key takeaways from this module are various anti-epileptics are available for use in patients with seizures, with the choice among them based upon evidence-based guidelines and patient and drug-specific factors. The management of status is similar in adult and pediatric patients. Number 3, certain drug classes commonly used in ED should be avoided in patients with myasthenia because they can worsen the crisis. And lastly, conducting research in ED is challenging because of the need to provide prompt treatment and obtaining informed consent from patients to participate in studies. This concludes the module, and I would like to thank you for participating.